Okay, hi guys. This is my presentation on pituitary adenoma, and I'm going to talk about I'm going to give you a quick overview of what a pituitary adenoma is. I'll talk a little bit about the clinical picture and the pathophysiology, and then dive straight into diagnosis and then a bit of treatment as well. So if you guys have any questions, feel free to just get in touch with me, or you can also just leave a comment down below, and I'll get back to you as soon as I can. So overview first of all. So a pituitary adenoma is categorized as a benign growth as opposed to a malignant growth. What can help you in discerning this is the name adenoma. The suffix should help you with that, and the word adenoma as well should indicate benign growth as opposed to malignant. So it's a benign growth, it's sporadic, and it arises from the anterior pituitary gland as opposed to the posterior. Posterior is called the neurohypophysis, anterior, as we know, is the adenohypophysis. In terms of etiology and a bit of information about the epidemiology, like I said, it's mostly sporadic. There's no clear linkage or clear linkages haven't been found, but there is some evidence showing familial predisposition or association with certain syndromes, for example, multiple endocrine neoplasia type 1. Epidemiology. It's in terms of rarity, it's not incredibly rare, but it affects typically 80 in every 100,000 individuals, and this statistic is from developed countries, typically affecting middle-aged population, males to females equally, and pituitary adenomas make up about 15% of all primary intracranial tumors. So in terms of the pathophysiology, we can say that the adenomas themselves are very well circumscribed, and they're intracellular. So this is an anatomical location, which means that it's located inside the sella tertica, which is the housing for the pituitary gland. And the way we classify the adenoma itself is there are two ways of classification. So one way of classifying is according to its size. So we can talk about micro versus macro adenomas, and it's very easy to remember the differences. So a growth less than 10 millimeters, or less than or equal to 10 millimeters, is classified as a microadenoma, whereas anything larger than 10 millimeters is categorized as a macroadenoma. We also have non-secretory adenomas as well, and secretory adenomas. Apologies for the bullet point, it's in the wrong place. But secretory, meaning that it obviously secretes a hormone or multiple hormones, and non-secretory being the other category. And this means that it's an adenoma, but it's not actually functioning. It's not producing any hormone. So size, macro versus microadenoma being one classification, and then the function, whether it's in terms of its secretory potential, so a secretory or a non-secretory adenoma. And we can use the words interchangeably with functioning or non-functioning. Just a note as well, so non-secretory adenomas can result in hypopituitarism, and secretory adenomas, so ones which do produce the hormones, can result in hyperpituitarism. So just a bit more detail, when we break down the different cell types that are found in the anterior pituitary, we have lactotrophs, so these are producing prolactin. So the pathophysiology, if the adenoma involves the lactotrophic cells, obviously clinical findings would be hyperprolactinemia. Hyperprolactinemia will present in slightly different ways in males and females. So in males, it'll present as a reduced libido, so that means a reduced sexual drive, and it can also lead to infertility. And in females, galactorrhea, amenorrhea, and a reduction in bone density. This is because of its relationship with estrogen. Somatotroph adenoma, so obviously elevated growth hormone, somatotropin. This can lead to and present as either acromegaly or gigantism in patients. A corticotroph adenoma, obviously elevated adrenocorticotropic hormone. This can lead to secondary hypercortisolism or Cushing syndrome. Thyrotroph adenoma, elevated thyrostimulating hormone, similarly to before, leads to secondary hyperthyroidism. Just a quick note, secondary meaning the pathology is caused by something other than the initial stimulating factor. So for example, hyperthyroidism, we're not talking specifically about the thyroid gland, otherwise that would be primary. So a thyrotrophic adenoma causes secondary hypothyroidism. Gonadotrophic adenoma obviously the gonadotrophic cells produce luteinizing and follicle stimulating hormones, so elevated levels of both can be found in the blood. In terms of the diagnosis can be made based on presentation first and foremost. So a pituitary adenoma can present with mass effect symptoms. There can be symptoms of either hypo or hyper pituitarism, and also pituitary incidentaloma. This is just a word to describe pituitary adenoma, which is found on incidental findings. So it's as a result of something unrelated. So a scan was made, for example, and the pituitary adenoma was discovered. So based on the presentation, the management would be slightly different in clinical practice, and this will obviously vary from country to country and from hospital to hospital. But first and foremost, one thing we will usually do is to do a clinical assessment. The visual field testing or neurological exam can be done at this stage as well. Imaging studies, MRI with IV contrast is the gold standard. CT with IV contrast is usually used as second line, and CT with IV contrast can be used as a diagnostic tool or for preoperative planning. Hormonal assays. So in hormonal assays, we are specifically looking at serum levels of various hormones, for example, prolactin or TSH. Visual field testing, like I mentioned, this is important when we're thinking about compression of the optic chiasm because of the very close proximity to the chiasm. And this is usually decided based on the imaging itself. So imaging is done first, and then visual field testing can be done afterwards. If the patient presents with visual symptoms, then obviously visual field testing takes priority. Characteristic finding, if there are visual symptoms, would be bitemporal hemianopsia. So this means loss of vision in the temporal fields. So the lateral halves of the visual fields on both eyes, because the bitemporal fields or the tracts rather from the bitemporal fields are interpreted close to the area where the pituitary gland sits, or the stalk of the pituitary gland sits in the midline. There are other diagnostic tools we can use as well, which aren't commonly used, but histopathology to show markers of proliferation, and also genetic testing, like I mentioned before. It's not routine, but we can consider genetic testing if the family history indicates this. And for treatment, first and foremost, will obviously be to stabilize the patient. So if there are any hormonal imbalances, we can try and correct this. We need to triage them, obviously, to neurosurgery if there are any severe visual defects, any alarming red flag symptoms. But in terms of the treatment, there are really just three options we have. So pharmacotherapy, surgery, and just observation. So pharmacotherapy is typically used for prolactinomas or those who are unsuitable for surgery. So it's like a second line really for those patients who are unsuitable for surgery. So for prolactinomas, we can administer cabergoline or bromocriptine. Cabergoline is first line, bromocriptine second line. For ACTH secreting tumors, somatostatin analogs, so pasiriotride, or glucocorticoid antagonists, like I've mentioned, for example, mifepristone. Growth hormone secreting tumors, so again, we can administer somatostatin analogs, for example, octreotide with or without cabergoline, and also growth hormone antagonists. And for TSH secreting tumors, again, somatostatin analogs can be used. Surgery is typically an option for those patients who have other secretory adenomas, so other than prolactinomas, or if they have any symptomatic non-secretory adenomas. And the approach is usually a transsphenoidal hypophysioctomy, either a partial or a complete resection, again, depending on symptoms, depending on the mass effect. And observation is typically reserved for patients who are asymptomatic. So they either have an asymptomatic prolactinoma or another non-secretory adenoma. So that's everything. Hope that covers all the basics for you guys. My sources were AMBOSS. And like I said before, if you have any questions, don't be afraid to drop them down below.